It's Friday the 19th of April and this is the Hot Topics podcast. Welcome once again to the Hot Topics podcast from MB Medical. I'm Neal Tucker and we've got a jam-packed podcast today. The main event is a fantastic interview I did earlier this week with two of the authors of a very recent clinical practice paper published in the BJGP on whether it's worth doing a digital rectal exam for prostate cancer screening or not. It's a great paper. It's an even better interview. It's a classic general practice conundrum. I'm sure most of us doing these digital rectal exams suspect it's got limited clinical value, but we still do them regardless. So do listen to that at the end of the podcast. We've got two papers today, both with a cardiovascular theme. The first is in the BMJ. It's looking at atrial fibrillation and then the long-term risks associated with that. The second is in the BJGP, focusing on patients with hypertension and how we can work out better what the risks associated with that in patients are. First, we're quickly going to think about the news. So NB news first. We've got a new cardiology and ECG course coming out next week. So Saturday, the 27th of April, it's an online webinar. Do join us for that. If you want to refresh yourself on ECGs, if you want to upskill yourself on ECGs, this is the course that you need. Beyond having loads of ECGs in it, we'll also be talking about some of the latest updates in cardiology and cardiovascular medicine. If you want to know what's been going on more broadly in the recent medical literature, then join us on Thursday, the 25th of April, for our latest Hot Topics course. That's another online live webinar. Want to come on both of them? Don't forget to subscribe to NB Plus, our subscription service. Check out the website for it. If you're going to come on more than one NB course in a year, it's more cost effective to sign up to NB Plus. Then you can come on all of our courses and much more besides. In the general practice news over the last few weeks, well, things, of course, are bubbling on with the England GP contract. The BMA is now officially in dispute with NHS England, rather than, obviously, the non-official disputes that we seem to have been having for many, many years. I was at the gym the other day. Now, I'm not really a gym guy. I'm not like a sort of a big stacked guy trying to get really big muscles. I'm mostly trying to rehab my knees so I can do what I really want to do, which is be out there on my bicycle cycling. Anyway, I'm surrounded by all these like really fit young people and some of these kind of like massive stacked people who are clearly on steroids. And I'm trying to drown out the relentless hard R&B that gets played at my local gym by listening to The Rest is Politics. If you've never listened to it, it's a great podcast. Try listening to it. I dare say it might even be better than this one. And one of the two hosts, Alistair Campbell, commented that the BMA was one of the most effective unions in the UK. High praise indeed. So fingers crossed, let's see what comes out of all of this. That will do for news for now. We've already got lots to fit into this podcast. Let's get on with the research. So first up is this paper in the BMJ. This is titled Temporal Trends in Lifetime Risks of Atrial Fibrillation and Its Complications. Perhaps this piqued my interest this week after having a very in-depth discussion with one of my patients at the practice about his AF and early heart failure and what to do about it, both medical and non-medical treatments. AF is already a common problem. 1 in 45 people in the UK have had a diagnosis. You suspect there may be lots who have also not had a diagnosis. And I suspect we can also all agree that AF is bad. Why is it bad? Because we always think about the increased risk of stroke. So that's where we tend to focus our efforts. But it's easy to forget to think holistically and perhaps consider the other important problems with which AF is associated. The aims of this study then were twofold. Firstly, to look at the changing rates of AF in the Danish population, and secondly, to quantify the long-term downstream consequences of having atrial fibrillation. This then was a cohort study undertaken in a Danish population, 3.5 million individuals aged 45 plus with no followed up over time, and if they developed incident AF, then they were then followed up until they developed another cardiac issue, either heart failure, stroke, or MI. Because the authors were clearly overachievers, they also looked at two different time periods. The first was from 2000 to 2010, and the second was 2011 to 22. The first important finding is that the lifetime risk of developing atrial fibrillation was 28% in this population. It was actually more prevalent in the more recent cohort than in the earlier cohort. So from 2000 to 2010, around 1 in 4 patients ended up having atrial fibrillation. From 2011 to 2022, it was around 1 in 3. When you compare the population characteristics of these two time groups, you find that the age of diagnosis of AF was essentially the same between the two of them, but the more recent cohort has higher rates of hypertension, type 2 diabetes, and dyslipidemia. And it just suggests, I think, that the population over that time, even a fairly short space of time, has actually become less healthy in general. As we see increasing rates of overweight and obesity around the world, you wonder if this is a sign of things to come. The second big result was around the lifetime risk of complications having had a diagnosis of AF. Stroke, of course, forefront in our minds. If you have a diagnosis of atrial fibrillation, there's a 21% lifetime risk of having a stroke, which is pretty high, right? It's a compelling argument for getting people on anticoagulation. But stroke was not the highest risk. So that was heart failure. 41% of these patients would develop heart failure over the course of their lifetimes. And of course, while no one wants a stroke, heart failure has terrible prognosis. The authors conclude that lifetime risk of atrial fibrillation increased over 2 decades of follow-up. In individuals with atrial fibrillation, around 2 in 5 develop heart failure and 1 in 5 had a stroke over their remaining lifetime. Stroke risks and heart failure prevention strategies are needed for people with atrial fibrillation. That then I think is probably the key learning point here. So as well as thinking about stroke when we make a new diagnosis of AF, let's also think more holistically and think about the possibility of heart failure. And then even if they don't have any indication of it now, let's think about what we can do to minimize the chance of developing it in the future. Look at those risk factors for cardiovascular disease and modify them where possible. Our second paper is in the BJGP this month with the title Prediction of Cardiovascular Events in Older Patients with Hypertension in Primary Care. This was another cohort study. This comes from the Netherlands, much smaller this time, 530 participants aged 60 to 85. And the aim of the study was to look for accurate risk stratification in patients with hypertension, thinking obviously about their chance of having cardiovascular events in the future. And initially, when I saw this, I thought, well, you know what, in the UK, we, of course, use Q-risk to think about people's future cardiac risk. So maybe this paper is not so relevant to us. But actually, it's exploring this issue with an entirely different approach. It asks whether the tests that we already undertake when someone gets a diagnosis of hypertension could be more useful in accurate risk stratification. It also asks if other tests that maybe we could do in general practice may also be of use here. Firstly, it notes that many national guidelines for hypertension recommend patients should have an ECG. This is in the NICE guidelines. I wonder if we're still great at doing that. I wonder if every patient that you make a diagnosis of hypertension on gets an ECG. Might be an interesting little audit. Well, of course, we're looking for cardiac abnormalities on the ECG, and one of the things that we're particularly looking for is left ventricular hypertrophy. This has been shown to have prognostic value for future cardiovascular events, but the ability of an ECG to detect this is not that great. The sensitivity and specificity is not that great, and that's before we've even started questioning whether we as the clinicians are going to be very good at actually identifying it when it is on the ECG. Echo is much better, but obviously we can't do that in every patient who simply has a diagnosis of hypertension. The key question that they're asking in this paper then is, could serum BNP be a useful biomarker for future cardiovascular events after a diagnosis of hypertension? The authors then recruited patients from 5 Dutch general practices starting in 2010. Patients had a new diagnosis of hypertension and then underwent blood tests including BNP, ECGs and echo. They were then followed up for up to 9 years, looking for new cardiovascular events and recording all-cause mortality. Over this time, 6% had a heart attack, 8% had a stroke, 10% developed AF, 4% heart failure, and 12% died. When they compared the initial investigation findings with the ultimate outcomes for patients, sure, left ventricular hypertrophy on an ECG or echo was associated with an increase in all-cause mortality, but the key finding was that a raised BNP showed the biggest difference over time, with a raised BNP being linked with an increase in cardiovascular events. Now, quite a bit of that was driven by increased rates of heart failure, as you would perhaps expect with someone with a raised BNP. But it wasn't just heart failure, you get an increase in other types of cardiovascular disease as well. Another interesting point to come out of this, and it took me a while to realise this when I was going through the paper, was that the threshold that they consider a BNP to be elevated is based on the European guidelines, and it's about a third of what UK guidelines set as our threshold for further diagnostic tests into possible heart failure. So even patients with a comparatively low BNP exhibit increased risks of future cardiovascular events. What does all of this mean in practice? Well, I think the most important learning point is that given the knowledge that if we have a patient with increased BNP, they have an increased risk of future heart failure, and that allows us to be more targeted with the treatments that we may offer them. So they've just been diagnosed with hypertension. Lots of them would be put on a calcium channel blocker initially, but that may not be the preferred choice, in fact. Rather, an ACE inhibitor might be better if you have a raised BNP, because that's obviously going to be more useful in heart failure. And it may just be, given that we know that ACE inhibitors in early heart failure can help remodel the heart back towards a healthier state, it may be that then has a protective effect. Of course, this is where the data runs out for us on a practical general practice level. But if you were going to be choosing between two pretty similarly effective medications, but one of them has a potential benefit in another area, then it seems to me that might promote itself as a preferred option. Of course, then you get into the next steps of thinking, and this is also true with our patients who have been diagnosed with atrial fibrillation, who have obviously got a very high chance of developing heart failure in the future. Is there a role for early beta blockers or an SGLT2 inhibitor? And of course, again, here, we just don't know the answer to that. But I think the key here is just thinking holistically for these patients and not feeling that we should be too tethered to existing guidelines. And perhaps that idea about challenging established practice neatly segues us into our third paper and interview for the day. This has come about because there's been a new clinical practice paper published in the BJGP in March 2024 with the title, "Is the digital rectal exam any good as a prostate cancer screening test?" I suspect that most of us would feel this is not a good test, but I suspect also that most of us are doing this on a regular basis regardless. So I think it's really nice that the BJGP have published this paper examining whether the digital rectal exam does have a role in this context. So I'm joined by two experts in this area. So Amy Rylance, who's the head of improving care at Prostate Cancer UK. So Prostate Cancer UK have been working with MB Medical to help make this interview happen. And also Sam Merriel, who you may remember from one of our podcasts a couple of years ago. So he's a GP up in Manchester and also an academic clinical lecturer. Welcome to you both. Perhaps we can start with some quick introductions. Amy, over to you first. How are you?
I'm very good, thank you. Thank you for having me along today. I'm really looking forward to talking about this topic because it is such a big issue when it comes to men's views about prostate cancer and getting tested for prostate cancer. So very keen to have a good discussion about it.
How did you come to be involved with Prostate Cancer UK, Amy?
So I've worked in improving healthcare since 2010. I worked first in Bradford District looking at issues around health inequalities and how we can narrow some of those health inequalities. I then worked in diabetes and looking at some of the challenges around diabetes care. Unfortunately, my dad actually died of prostate cancer, and when I saw this job come up at Prostate Cancer UK, it was about 5 years after he died, and it just felt like where I needed to be. You know, it was a perfect alignment of something that I care very passionately about and an area where I have skills and experience.
Thank you for sharing that. I think there's often a strong personal connection that does drive people into certain paths. Sam, could you briefly introduce yourself?
Yeah, thanks, Neil. So I am a GP working in the northwest of England. And yes, I'm also employed as a lecturer at the University of Manchester. Most of my research is focused around helping GPs pick up cancers earlier. Not limited to prostate cancer, but a lot of my work is in prostate cancer. I find it a really challenging clinical area. There's so many sort of unknown areas. And as with a lot of cancer-related research, there is a dearth of primary care-focused research. So a lot of evidence that gets applied to primary care practice comes from screening trials or secondary care studies. And so I'm working on filling those gaps and trying to generate some relevant evidence to the primary care population.
I think that goes right to the heart of things because we in general practice are intrinsic in identifying this cancer as early as possible in our patients. And this is a big issue. So a Lancet Commission on Prostate Cancer just published in the last couple of weeks. It's open access. I'll pop the link in the podcast description if you do want to have a look at it. But it just highlights the scale of the problem. 2020, 1.4 million cases of prostate cancer was diagnosed worldwide. In the next 15 years, that's going to double. So this is a huge issue and it's only going to get bigger. So what we need is good research to help make good guidance to help us identify prostate cancer as effectively as possible. And of course, the starting point then is what tests are actually useful. Let's then come back to the question that your new paper asks. Is the digital rectal exam any good as a prostate cancer screening test? Amy, let's kick off with you.
Short answer, no. There is a lovely, emphatically titled paper which says the digital rectal exam is not a useful screening test for prostate cancer. What it found is that as a standalone test, its performance is very poor, but also in conjunction with PSA, its performance is very poor. Now, earlier this year, there was also a full systematic review and meta-analysis published that concluded the exact same thing. So it describes the DRE as having notably low diagnostic value and suggested that it is time to start removing it from our standard practice when it comes to diagnosing prostate cancer.
I suspect this won't come as a surprise to most clinicians working in primary care. The reality is that most of us will have felt very few prostate cancers, or indeed maybe none at all. Perhaps it's worth just thinking a little bit about what are we feeling when we do a digital rectal exam. Sam, maybe you could come in on this one for us.
Yeah, it's a good question. So I guess going back to your anatomy to start with. So when you examine the prostate via the rectum, you're feeling the posterior side of the prostate gland. So you can't feel all the way around the gland, so you don't feel the anterior part or even the lateral side. So you're only feeling part of the gland. And that's part of the reason why it's not a really great test, is that a lot of tumours you can't even palpate. So a normal feeling prostate shouldn't be reassuring that there's no cancer there. It's just that it might be somewhere else in the gland.
Okay, with all of this in mind then, is there ever a role for digital rectal exam in the context of possible prostate cancer then? Is there any situations where doing this test is useful? Maybe Sam.
I know we said we wouldn't go into symptomatic assessment too much, but I think that's where it potentially has a bit of a role. So yeah, totally agree with Amy and the reading of the experts on the evidence around as a screening test that DRE doesn't add anything. There is a a systematic review by Daniel Jones, who's another academic GP in the north of England, looking at studies of symptomatic men presenting in primary care. And there's 4 studies that have ever been done in this. They're very small studies. The quality's not brilliant, but the summary was that actually, if a GP thinks the prostate feels abnormal in men presenting with symptoms, the likelihood of cancer is well above NICE's 3% threshold. Their estimate of how much, it really varied because the studies were relatively poor, but they all said it's above the 3% threshold. So I think in that situation, if you do see a man with symptoms and you do an examination and it doesn't feel normal, then GP should just refer. I think if the PSA is elevated, as we said in our paper, DRE doesn't add anything. So if you're assessing a man and they've done a PSA for whatever reason, if they come asking for a screening test or you're assessing a man as part of a symptomatic assessment and the PSA is elevated, there's no need to bring them back and do a DRE. It shouldn't change management. As I said before, a normal feeling prostate should not be reassuring to a clinician who has a suspicion of prostate cancer that it's not there.
I can appreciate that if we feel what we consider a sinister feeling prostate, that's going to increase someone's risk and they obviously need to be referred. But I guess the big question is, if you've done a PSA, how often, given the fact that it seems vanishingly rare we identify a sinister feeling prostate, how often is that actually going to change management doing that digital rectal exam?
So there's a really interesting study that was published in the New England Journal of Medicine a while back. And God bless people who take part in medical research. They recruited a huge cohort of men and they gave them an annual PSA and DRE for 7 years. At the end of 7 years, there were a cohort of almost 3,000 men who had never had an abnormal PSA or an abnormal DRE. And those almost 3,000 men were then given a biopsy. So, men who appeared to have no indications of prostate cancer were biopsied anyway to see whether they could find any prostate cancer.
That is dedication to the cause of medical research.
Yes, absolutely. Absolutely. What was really interesting about that, and you see this figure quoted a lot, is that about 15% of those men, they did actually find some prostate cancer. And you see that figure a lot in terms of saying why the PSA test isn't a useful test for prostate cancer. I think there are some important caveats to that research. So actually, when you look at the paper, the vast majority of those men were diagnosed with Gleason grade 3+3 prostate cancer, which is what we would typically call overdiagnosis. So it's the cancer that actually we don't want to find. And so the fact that they were missed on a PSA and a DRE is a good thing. 2% of those men did have clinically significant prostate cancer and had 7 years of normal PSAs and normal DREs. And I think those are the men for whom there is always a bit of anxiety that actually the PSA test is not a perfect test at finding all the men with clinically significant prostate cancer. There will be 2% of men for whom the PSA test has missed them. But actually what that research showed is that the DRE missed it too. But I think sometimes when faced with a man, particularly where there is a really significant additional risk. So, for instance, because of a very strong family history, it may be that the DRE can provide that extra layer of reassurance, either to the clinician or to the patient themselves, if they are particularly concerned about their risk of prostate cancer and the PSA test is coming back normal. The DRE can be that extra layer, but there's not much evidence that shows that the DRE will actually pick up cancers that the PSA test is missing.
And when we're just thinking about factors that may lead to an elevated prostate cancer risk, maybe just remind us what they would be.
Age is the big one. Your risk gets higher as you get older. But again, we shouldn't be looking for prostate cancers in very old men. And actually, there's some new guidance that's come out very recently saying don't do a PSA test in a man over the age of 80 unless you have a significant concern around metastatic disease, because actually it's not very helpful to men who have a much shorter life expectancy. The treatment will likely do them more harm in their lifetime than the cancer will. But the 3 other risk factors to be aware of are Black ethnicity. So as a Black man, your risk of being diagnosed is double. your risk of dying from prostate cancer is double, and your risk starts at an earlier age. So from the mid-40s for Black men, their risk increases significantly. The other risk factor is family history, and the stronger the family history, the higher the risk. So multiple relatives indicate a higher risk. And the third risk factor, which is quite a new one, but as we are increasingly learning about genetic risk factors. So in the UK, we now have a BRCA screening program for anyone with Jewish heritage. Those men who go for BRCA testing and discover that they have the BRCA gene, they have a significantly higher risk of prostate cancer. And again, starting at that earlier age for all of those three categories of men at higher risk.
I think the idea about doing a PSA test in younger men, so men in their 40s, is quite an interesting concept and certainly might be a change in practice for many of us. It also highlights our need to be more mindful about risk factors and perhaps a bit more proactive in those groups as well, given they're more likely to have aggressive prostate cancers at a younger age. We've talked about some of the reasons why you may or may not want to do a digital rectal exam, but are there times when the idea of a digital rectal exam could lead to worse outcomes?
This is something that we at Prostate Cancer UK have looked really closely at. So we've done a couple of very large pieces of market research. So one where we had over 2,000 men and we checked what their understanding was around prostate cancer and how it's diagnosed. And what we found is that 60% of those men were concerned about having a rectal exam. And of those men, 37% said they would not speak to a GP because of that concern. So there's a really significant cohort who simply won't come forward because of the concern about the rectal exam. Now, we thought that was some really interesting findings. So we did a separate follow-up piece of research with over 1,000 men, where what we did was we took over 30 statements that encapsulated common barriers that we hear from men and clinicians about why men don't come forward. You know, it's that, it's not manly, it's embarrassing, I'd have symptoms if it was cancer, all these kind of things that we hear in the ether about why men don't get diagnosed until late. And we asked men how much they agreed with those statements. And one of the statements was, well, the first test for prostate cancer is a rectal exam. We then asked the men who'd completed this questionnaire whether they wanted to take a really simple health action in relation to prostate cancer. So we asked them if they wanted to do the Prostate Cancer UK's online risk checker. And what we found was that the men who agreed that the rectal exam was the first test, which was roughly half of all men, were the least likely to be willing to take an online health action around prostate cancer. And so what we can infer from that is actually concern about the rectal exam and belief that you will have to have a rectal exam as the first test is the single biggest factor that puts men off speaking to their GP about concerns. And I think just going back to our conversation about the men at risk, actually what we can see in this research is that we had a very large sample of Black men in this research, and we can see that this is a bigger cultural issue for Black men. And so maybe more of a factor putting them off from coming forward. So that's where I think it's really important that we don't create unnecessary fear and anxiety about coming forward and discussing risk of prostate cancer for a test that, as we've just discussed, is not very good at finding prostate cancer.
It sounds to me like even the concept of a digital rectal exam in this context may be doing more harm than good. With all this in mind, do you think we should still be doing a digital rectal exam when screening for prostate cancer? Sam, what do you think?
Yeah, I mean, I think if in the screening context, it's pretty clear it doesn't really add much. And as Amy's highlighted, potentially doing more harm. It's also interesting that it's not just in a primary care context that DRE is becoming less in favour. So there's been recent changes in terms of the way prostate cancer is diagnosed. So what's called multiparametric MRI has come into the diagnostic pathway. So brief thing, because I know a lot of GPs don't know a lot about prostate MRI. So since 2019, the standard of care now is any man referred from primary care with suspected prostate cancer, whatever the reason that they come through primary care, the first test they get offered is an MRI of the prostate. So it's almost never straight to biopsy now. And MRIs come in because the trials done in the UK and in Europe have shown that if you MRI before biopsy, and you see something abnormal on the MRI, it helps the biopsies become more accurate because now they're targeted, whereas the old ultrasound-guided biopsies were essentially a random sample of the prostate. Now they're doing targeted biopsies of areas that look abnormal on the MRI, but also really crucially, if the prostate on MRI looks completely normal, the chances of having a significant prostate cancer are really small. And so the vast majority of men we refer from primary care now have an MRI that's reported as being normal will come straight back to us and they won't go through biopsy. MRI is not a perfect test either. So men who are very high risk, or let's say they've got a really high PSA, but the MRI is reported as normal, the urologist might still suggest that they go for biopsy anyway. But the vast majority of men with a normal prostate MRI will come back to us. The other advantage of MRI is you get a really accurate measure of prostate volume, which they can put together with the PSA, and it's another marker of the risk of prostate cancer or not. And so because it's such a good test, and there's a lot of urologists saying, well, I don't routinely examine men anymore because it doesn't add anything on top of the MRI I'm going to send them for. So I think that's something that all GPs, we're trying to spread the word, and the work I do with the Prostate Cancer UK a lot about is updating GPs about changes to the diagnostic pathway that have come in the last 5 years and how that's then changed the risks and benefits of being tested, overdiagnosis, risks from unnecessary biopsies. How much that balance has changed in the screening context, we're still learning, and there's trials that are starting to come out with results overseas that are where they've done screening MRIs in a variety of ways, and there's big things coming in the UK too. So it is changing how prostate cancer is being diagnosed.
So to summarise, it sounds like the digital rectal exam is not a useful test for the vast majority of men in the screening context. There may still be some role for it in the context of symptomatic men. That's a different group. It sounds like the concept of the digital rectal exam is actually putting off men from coming to see us to discuss their concerns about prostate cancer. And in particular, that may lead to us missing some of the higher risk or the highest risk groups, which in fact we want to be taking a more proactive approach in testing. And then the other big learning point seems to be that whilst we all appreciate the limitations of the PSA test, and it's far from a perfect test, actually the technologies have changed, the pathways have changed for diagnosing prostate cancer. And what that really means is that men who have a raised PSA and we're referring into a cancer pathway, we're better at selecting patients who may genuinely have life-threatening cancer. So more men who are normal or who have indolent cancers are filtered out early so they don't have to undergo those more unpleasant tests such as biopsies. This changes the risk-benefit ratio, so whereas in the past maybe we've been neutral or even a little bit negative about the thought of doing PSA tests in men, it sounds like things are swinging the other way and perhaps we should be more positive about the PSA and its role in identifying early significant prostate cancer.
That's a good summary.
Fully agree. I mean, our position is that the PSA test is a pretty cheap and safe way of working out who would benefit from an MRI test. And that's the crucial difference between the pathway 5 years ago, where the next step was the biopsy, which is an invasive test that can have significant side effects. But we're in a very different space now that we have MRI within that path.
Fantastic. Well, it's been really interesting talking to you both today. If you, the listeners, do want to check out the paper, so as I say, it's in the March edition of the BJGP, so that's 2024 in case you're listening to this in 3010, and it's open access as well. So I'll put a link to the paper in the podcast description. I'll put links to some of the research that Amy and Sam have talked about as well, so that you can take a look at that if you want to. And it just leaves me to say thank you so much, Amy and Sam, for joining us today.
Thanks, Neil.
Thank you.
Well, I hope you have enjoyed the podcast today. Thanks for listening once again. Don't forget to check out the mbmedical.com website for all of our courses coming up. Do join us for that new cardiology and ECG course. It's going to be absolutely fantastic. Remember, you can always get in touch, hottopics@mbmedical.com if you want to email or find us on Facebook and Twitter. And I'll be back in a few weeks. Take care. Bye-bye.